Welcome, welcome, one and all, to Reunion 2020 at the UIC College of Nursing. I'm Steve George. I'm Assistant Dean for Advancement. My team puts on events like this and will be with you throughout the day. So let's get going on the discussion. Today's moderator is none other than Dean Terry Weaver, the 8th Dean of the UIC College of Nursing. Friends, I present Dr. Weaver.
Thank you, Steve. So good to see you all. Good morning, and thanks for getting up, or some of you are in the evening. Appreciate that you've joined us from all over. And I want to welcome alumni, faculty, staff, and guests to our Reunion 2020. As you may know, and Steve might have mentioned, this is my last reunion with UIC College of Nursing, and it will probably be the most memorable one as well. Not quite the one I had anticipated. So when we talk about reunion, it comes from the verb to reunite, to bring together again. The completely virtual format of this year's event, intended to bring our community together again, is perhaps not exactly as we would wish. Hard for me to give you hugs from afar. But as yet, this year, nearly 250 people have registered to attend, a count that exceeds any prior year's reunion registration number, which is terrific. Perhaps that's because of the very easy travel. My commute was very short as I welcome you from my home, especially for those of you joining us from great distances, some even from the other side of the globe. Or perhaps it grew from an urge many are feeling, to connect with others during a prolonged period of unwelcome separation. I hope a large part of the reason you're here is that you saw in today's offering exactly what we always mean for our reunion to be: a day of celebrating alumni, friends, faculty, students, staff, supporters, our entire UIC nursing community, as well as an opportunity to re-engage with us in a way that's valuable to you. I also hope today inspires you to learn more about the UIC College of Nursing as it is today. I encourage you to read our 2020 issue of Vital Signs magazine, which will be arriving in your inboxes and mailboxes in the coming weeks, and which tells truly amazing stories of our college and of your fellow alumni. But for now, let's focus on today, which I know will be very enjoyable. I have long believed that a college is best measured by its alumni and the contributions they make to the world. This morning's 3 panelists loom large among the many alumni who give UIC Nursing our very strong reputation. Brenda Burke is Associate Director of Patient Care Service and Nurse Executive at the Jesse Brown VA Medical Center in Chicago. She earned her DNP with us in 2015, making today her 5-year reunion. Congratulations, Brenda.
Very much.
Brenda, thank you for being here and welcome to the panel.
Thank you.
Lynn Lenker is Chief Nursing Information Officer for the system of SSM Health in St. Louis. She's also a member of our External Advisory Board. As a 1995 graduate of our master's program, she's one of our esteemed Silver alumni, celebrating her 25th year reunion today. Lynn, welcome. We're happy to have you and thank you for joining us.
Thanks, great to be here.
Sarah Overton is a 2-time alumna of our college. Having earned her BSN in 2010, she's celebrating her 10-year reunion and her MS in 2017. She is now Vice President and Chief Nursing Officer of Clinical Services at Order of St. Francis Multispecialty Services in Peoria. Welcome, Sarah, and thanks for being with us today.
Good morning. Thank you.
All right, let's get into it. Now, to get us started, I'd like to ask each of you to please share a little about yourself by telling us, why did you become a nurse? Why did you choose the UIC College of Nursing? And what path led you to become a nurse leader in your current position? Sarah, let's start with you.
Great. Well, thank you so much. Welcome to everyone. Appreciate the opportunity to speak to you all. I think it's very easy for me. We were honestly a family born and bred in medicine, I would say. From a very young age, sitting around the dinner table, we talked all about nursing, medicine. So it was just very natural for me in my career. I was always interested in the sciences, and of course the art of nursing was a passion of mine. So I started off very early on knowing exactly what I wanted to do. And when I got into nursing, had a very short stint actually in the hospital, and then transitioned to ambulatory nursing, where I found just a significant opportunity to impact our patient populations. And I felt that really the background and the connections I had, again, with my family, one of my grandfather was a physician, and I used to support him in his clinic actually, and knew his community and his patients really well. And I felt that we needed to bring that leadership and structure into OSF. So that really motivated me to really obtain a leadership position and start really pushing for transformational care in the ambulatory setting to prevent just the admission and readmission issues and really transform healthcare, hopefully one patient at a time.
Wonderful. Brenda.
Oh, good morning. And Ms. Sarah, thanks so much for having us on today. My story is very different than Sarah's. My best friend, when we left high school, said, let's go to nursing school. And I said, are you kidding me? That sounds like the worst job ever. So I'm an adult learner. And when I had my first child, I was fortunate, had never really hadn't been hospitalized. And I was struck by the intimacy of the experience of letting these strangers into the birthing suite. But I felt such a dependence on them, such a need, such a respect for them. And I thought, wow, that's amazing. Pure strangers come together in very intimate experiences. So I was sold, not necessarily labor and delivery, but I was sold or just very intrigued by the field of nursing that allowed for those experiences. So went to school and became, my bachelor's, and became an ER nurse, which was amazing. Because it allowed me to enjoy the whole hospital in one unit. I didn't have to pick a specific passion. Why I chose UIC for my DNP, I finally found a program that was designed for me, for operational nurses. I was determined to get a terminal degree from the very beginning, and I'd never found one that was designed for nursing leadership as well as the UIC program was. In my day, we got ahead by coming to work on time, embracing the hospital's missions, but it was a lot of baptism by fire. So UIC really prepared me for the challenges of being a nurse executive. And then how did I get here? I often say kind of by accident. I had a little burnout as an ER nurse. I did that for about a decade, and then I thought, what next? So I wanted to stay in nursing, and was introduced to the world of operational nursing or leadership nursing, and just started pursuing that path. So I kind of mourned the loss of the hands-on nursing initially, but then I came to embrace operational nursing, because who better to lead nurses than nurses? Mm-hmm. So that's my story. Thank you.
Great story. And what is yours, Lynn?
So I had an unusual experience when I was about 5. I had my tonsils removed. And it was actually a nurse who helped me see that I probably needed to be a nurse. And so it was a lot of fun. And it's always been about caring for other people and being a part of a team. And so I thank you for the opportunity to really think back about that experience. As 5 years old, I probably wasn't the best patient. I sat up all night in the nurses' station watching the nurses, and I thought, this looks like a lot of fun. So that started me down that path, and I've never wanted to really be anything really different than just being a nurse. And it's just really been important. And why I selected UIC was it was the right time and the right, just the right place and the right time for me to go on for my master's. And they had a very strong leadership program in nursing administration. And knowing that that was the direction I really wanted to go in, to see how we could work better together as a team, and to keep pursuing that and wanting to be a CNO, and knowing that there was a good way to being able to lead people, I felt very prepared for all of that good work as I went forward. So thanks for asking about that, Terry.
You're welcome. Thank you for your great story. Now, I'm going to ask you another question, which is, how has your career prepared for you developing and acting on emergency protocols in your health system? Whether we're talking about public health crises like the current pandemic, or natural disasters such as fires or tornadoes, or perhaps tragedies such as mass shootings. Sarah, do you want to share with us first?
I'd be happy to. I guess I'd step back.
And since we've, sorry, Sarah, since we've kind of each had a turn to give background, the other two speakers can certainly chime in as you'd like.
Great. You know, I think I'd step back and say, I at least with this current pandemic, and I was in healthcare and supporting it during H1N1. We had the Ebola scare, definitely. But I don't think there would be anything right now that would have ever prepared us adequately in the current pandemic crisis. You know, I remember in late January, we started discussing it and talking about it and making plans. All those plans were great in theory. And then when it actually came to OSF, which we have 14 hospitals, and then I support those clinics around those hospitals. So a little company of Mary in Chicago actually was the first place to be impacted. And it was sheer tragedy, honestly, seeing patients come in. We had employees, which we call mission partners, actually as well affected and afflicted with this pandemic. It was very, very frustrating, I think, at times for our front line. So, you know, we took the opportunity, and it's very challenging also to not be able to connect with your nurses. Mm-hmm. You know, we were really frowning upon anyone getting close to the front line. So trying to do virtual interactions with them, such as this. I would say that the 2 or 3 things that come to mind for me was really agility. We work 7 days a week, often 10 to 14 hours interpreting guidelines, looking at what the state was telling us. And unfortunately, we have 2 states that we had to work through, with Michigan and Illinois. But looking at both states, and then also looking at the CDC and others. We support 1,200 physicians and advanced practice providers, so really connecting with them and having them help us design and develop medical guidance and how OSF is going to care for our patients. But we heard a lot. We went from really in the ambulatory setting, a complete furlough of probably 50% of all of our staff. Yeah. All the way to now we cannot continue to staff enough. We are struggling with staffing appropriately for our clinics, and by that we've developed some interim solutions to provide patient access, which is the virtual visit, which was a game changer for us in ambulatory. But I would say the agility, really making sure that we understood what the frontline needed, and then made some agile decisions on that. Transformational leadership, I think, comes to mind, being very transparent with them and telling them, we don't know, but we're going to try and find that answer out. Or you're right, I don't think this works. Let's try a different path. Mm-hmm. And then lastly, I think that just the servant leadership. I think we've definitely heard a lot of resiliency need. We've heard a lot of burnout from our frontline nurses specifically, and feelings of inadequacy, feelings that maybe you don't feel that you're listened to or taken care of, and we really had to step back and work towards different opportunities to support them. So we provided virtual lunch and learns for them. We equipped them with tools. We created an app so that they could get real-time information down to the front line. And this all happened for several months. So we had our incident command stood up for 107 days, I believe. We shut it down, and actually we've reopened it again because we're seeing such an increase. And in the midst of that, we had a significant fire. So we had a offshoot of the pandemic incident command that then we developed and had to transition a 45 physician cardiac center off-site. We had to move them in a short amount of time due to the smoke damage here that happened in Peoria. So I will say that I feel like I learn every day a new way to impact and probably embrace the frontline feedback and making changes accordingly.
Mm-hmm. Yeah, I would add to that. You use the term agility, and in the IT space where I was supporting nurses in the background, the biggest thing was being nimble enough to make sure that we could change our systems rapidly enough to support the people that needed that level of supporting. As the CDC changed their guidelines, we needed to be able to make sure that the screenings were changing to be sure that we were meeting all of those needs. And I think one thing that's really helped me as I've come along through, the nursing process and all of those different things is the understanding in IT, we always say, what is the problem we're trying to solve to help us keep the focus that we were going in the right direction? Because there was so much, as Sarah mentioned, there's so much going on that you want to make sure that you're doing the right things and that you're really being present in the right moment to deliver what needed to be delivered to those frontline staff people. And so knowing that we were right there as part of the disaster team, and I think that one of the things that also helped us prepare all the way along is some of the other things that have been in our history. Certainly in IT, one of the things is downtime is more important, is just as important as uptime. And so knowing and being prepared for some of those kinds of things helped us, so.
Thank you. So I would say yes to both Sarah and Lynn. So without repeating it, I've experienced the same type of struggles, but the word that comes to mind is flexibility. I used to I still do take pride in my ER days, ready for anything, but oh boy, no way to be ready for the pandemic. So transformation leadership, servant leadership, because I felt such a sense of responsibility for our front line, and we needed them to be there. So communication was so important in a 24/7 institution, and how we messaged what we talked about. We too were there 7 days a week, 10 to 16 hours a day, but it's a 24/7 facility. But one of the biggest things we had struggles with is, staff so desperately wanted guidelines as to what to do. And in one weekend, the CDC changed their PPE handoffing 3 times. And I had to ensure that the message was, no, we don't know. It's not that we don't know what we're doing. This is good that healthcare is constantly changing, because it means we're getting better at interpreting what the illness is required to keep us safe.
That's right.
So constant messaging, realizing that it was 24/7, explaining that changes were good in healthcare and that changes weren't signs of being inept, to be flexible. And as always, the answers are with the front line. So making sure that we tapped into them, because without any front line, there is no healthcare. So they really, they had all of our ears. And then the ELT, or our C-suite, working together to do things in a hurry. We stood up ICU units in a week, IT solutions. I mean, stuff that's happened, in a matter of days, weeks, and months that would normally take much longer. So everybody surrendered and work together as a team, and we are a much better healthcare system now than we were months ago. Not only where I work, but I think everybody as a whole, because we kept on learning despite being tired, but we needed to keep on learning.
So I think that, Brenda, your comments really lead nicely into the next question, and maybe you can continue to by answering it, which is what key elements has your organization put in place in terms of systems, trainings, drills, and the like to prepare for such emergencies?
So a lot of the traditional things, but the most important training that we made sure that everybody has gone through is the donning and doffing of PPE. And again, that's an example of stuff that's changed. You know, everybody has a fit test for their N95, but during the pandemic, we had more than one option for an N95. So then we had to have repeated donning and doffing and fit testing. So that, because that's paramount, that our staff stay safe. So everybody, 100% of the people have been trained in how to do that. And then we created a buddy system for any place that has to don and doff to ensure that it's done the right way and without cutting corners. The other thing that was very good, we stood up an incident command as well, and we found a manpower tool, and we interviewed all of our staff to find out what units they currently were in and what history they had in healthcare, from the food and nutrition people to EMS, because like Sarah had said, we pretty much furloughed our ambulatory care world, our outpatient world, and we trained them to be extenders of healthcare on the inpatient world. So this manpower pool is a great tool. I have a little snapshot of what everybody's history is in the organization with regards to how they can help us when the need arises. So we've kept that alive and up to date since this all started.
Sarah or Lynn, you want to comment on the question?
Yeah, I'd be happy to take that. That's a really great idea, Brenda. I know when we were looking at staffing, we did the same. Again, our hospitals were down due to the elective surgeries. There was a significant impact to furlough. And we did set up kind of a tiering system. So again, to your point, but I don't think we went to the level of interviewing and getting individual background. That's a really great idea. I think the one thing that we stepped back and noticed that we probably needed to heed and change, again, speaking about flexibility and agility, is our respiratory protection plan. We had in ambulatory a respiratory protection plan, which created the fit testing process, and we called it just in time. Unfortunately, we didn't have time and we didn't have PPE. So I think that really stepped us back for a while. This COVID-19 really has been a lot of community spread. Fortunately, majority of our patients actually are able to stay home and isolate. Unfortunately, they still need access to healthcare, which usually creates the process of either virtual telehealth visits or in-person visits with our clinicians. So we had to fit test over 1,200 mission partners across 100 plus clinics. So that was very challenging for us and has continued to be a pattern that we're working towards. And we're really focusing on that primary care team, which is the provider and that primary nurse. And the other elements that we've worked on is drive-through access. So drive-through flu clinics, drive-through testing for COVID-19, drive-through probably COVID-19 vaccines if and when those come to us. So we've really been drilling on those for quite some time, and it's really set us up nicely for flu vaccination, and we're off to a really great start, which is fantastic. And our patients, I think, are finally heeding the guidance of getting their vaccination for flu. So we're getting prepared now for COVID-19, actually.
That's great. And I'm sure, Lynn, IT had to think about several scenarios to be prepared.
Yes. So it was the location and expanding locations to areas that weren't necessarily even a hospital. If we were going to have to expand our care, we took over a hotel in one of our St. Louis areas and started in to get prepared and set it up on the IT side so that we could see the record from when they were in the patient, in the house, to moving to that care center. And we actually didn't really need to move many, we moved some, but all of those kinds of things as far as that level of preparedness. I think one other thing I would add, many of the things that, Sarah and Brenda have said are certainly what we did, but the other thing that I think we learned is the importance of partnering with other people to understand what that community impact was to the rest of us, and being able to share. And we actually started in several centers in many of the areas of the 4 states that were located, so that we could start to see what was happening around us, to make sure that we could get a better handle on, it's not just what we're experiencing, what is the region experiencing, so that we know what's coming next. So some of that partnership was just really very valuable.
Yeah, I can imagine. So you all, I think, commented on aspects of emergency preparedness, and you alluded to past situations. I know Sarah talked about SARS and Ebola. What about 9/11? Did 9/11 help you prepare your health systems and other threats that have come along? So in terms of management issues, PPE, I know you've talked about financial impacts, and then caring for the caregiver. Anything that stands out for you?
Yeah,
Lynn?
so, our organization had a little bit of an experience before 9/11, actually in 1995, when the Oklahoma bombing happened right down at the federal building downtown, and our hospital is only a couple blocks away. And I think that that was one of the things that really helped us understand that we needed to do something to get prepared to help the nurses and be there and be more supportive for them about what they were going to experience. And in 1995, what happened is they got prepared in a very quick order. They thought it was, a disaster kind of situation, but what they weren't prepared for was what we saw more in 9/11, is that the patients didn't come because they were dead. And so that experience of knowing how we had to really help the nurses in this pandemic, we have set up virtual Schwartz rounds for our nurses to attend, so that they can go with a person who is actually licensed and being able to do Schwartz rounds virtually, and talk about their experience and their feelings for what was happening and how out of control they felt everything was. And I attended a couple of those just to hear some of our people talk about the value of the Schwartz rounds, the value of what it brought to them, and how important that was, that we were paying attention to their overall emotional health as well. So I would say that some of that early learning was very valuable to us in being able to prepare and help our people.
I also wanted to ask you a little bit about challenges facing rural areas versus urban suburban areas. What do you see as similarities and differences? Also, what unique challenges face health systems that bridge across state lines? And you talked about that, looking at other states. And this is mostly also for Brenda. What unique emergency preparedness challenges face a federal system like the VA? Sarah, you might want to comment first.
Yeah, I can comment. We have a little slice of everything within our health system. So we've got several rural clinics that are one physician or one advanced practice provider in an extremely small community. We have several rural health clinics connected to our critical access hospitals. And then we've got very large urban, Chicago, Peoria. So we really have a mix of everything. What I've experienced and the feedback that I've received from rural community and rural health is access. Access is always a challenge. I think what's been very beneficial again for us is that virtual access. So being able to access your clinician from your home into their home. Unfortunately, rural America still struggles with some of that access, such as just the internet. Getting onto the internet has been challenging. Certainly, we have some very agile people like you all that are able to log into a Zoom meeting very easily. And then there are some that don't even have a smartphone. So really trying to teach patients of all backgrounds, the varying IT experience, I would say, and trying to troubleshoot with them. So we've had to really change things up. Providing access for COVID-19 testing for probably a month or two was very challenging. We did have the state come in some of our areas, but just the lack of testing, we had to partner with the state and federal government at times to basically allocate additional swabs, reagents, PPE to us so that we could start collecting on our patients. But, you know, it continues to be something that we're trying to be very strategic about. We can't put a primary care provider in every single community, and even far more removed as a specialist. So trying to get a subspecialist in pediatric neurology, for instance, it's not going to happen in rural America. But now that we have access to this, where you don't need a physical exam for every single encounter, you really just need that clinician expertise and then that connection to the patient virtually. It's really been a game changer for us. We're happy that CMS, I believe, fingers crossed, will continue to approve for telehealth visits, because it really does provide a channel for our patients to not have to travel outside of their footprint. They can stay locally, and then we can order the appropriate testing and whatnot. And just speaking very quickly, Illinois, of course, borders several states, and every single one of our practices is on a border. So really interpreting Wisconsin, Iowa, Indiana, and Missouri guidance. Every single one of the states has chosen to really look at things differently. So that's been pretty challenging for us to really interpret each of those guidelines. And I do share that we have a community in Michigan, which we happen to have Delta County. So Detroit happened to be impacted significantly in Michigan. That didn't become the case for Escanaba, where we have our practices and hospital, but now it has. Actually, we've started doing a real uptick there, and it's really getting them the access and the needs. So I hope that the federal government and others spend some time really looking at telehealth and changing our reimbursement models to provide that access continually, and we don't go backwards from here, honestly.
Brenda, what about the VA experience, being in a federal system?
Right. So that's been the blessing, because I'm part of 157 facilities. We're the largest employees of nursing nationwide. But having access to such a large system has really helped ensure that we had access to any type of materials that we needed, or PPE. So we've been very fortunate with that. We have reciprocity with our licenses in all states, so crossing the borders is not a problem. Sometimes our challenge comes from EMS Transportation, because they have regulations. We don't have our own EMS Transportation, but we've worked that out via contract. Where I'm at right now, I don't have any rural clinics, but in my past history we have. The VA, we have our guidelines. If you don't have access within X amount of days, depending on the type of care you need, we have care in the community. It's not something we prefer to do, sending our veterans to the community, but we want to make sure that they have the health care that they need. We actually did, like Sarah had alluded to, we have to do a push, because we do have VA Video Connect. That's been tremendous for keeping people connected to their provider. But there was a fear factor for people to go out, and we actually have to send messages and mailers to our veterans saying the ER is still open, it's a safe environment, do not stay at home while symptomatic, because we were seeing initially, by the time patients finally came in, they were so sick, and had they come in earlier, but there was the fear factor. So we tried to ensure that everybody knew that we were still open and available for them to come in.
Great.
You know, I think that that's a really important point, because we did start to see that people were so much sicker. One of the things that certainly Sarah and Brenda talked about, as far as in their systems of being so many, when you're thinking about that in the background, we were also trying to report out to all of those all of those regulatory agencies on the state level, our numbers. And we're doing that through different portals and trying to be sure that we were being as accurate as possible. And so the difficulty with it, with which everybody had different standards by which they wanted to understand the data, made that quite a challenge for all of us. And especially when from the rural areas, trying to get the numbers and things. I really wished that we had some of the same things that Brenda had related to saying that the licensure all across was the same and you didn't have that issue of worrying about the people that you were bringing in, but there were so many things that we had to pay attention to all of those different state rules.
Yeah, indeed. And so could you just elaborate a little more, Lynn, about the role or what the role should be for health information management and technology would play or does play in disaster preparedness?
Yes. So, one of the things, well, PPE was very short. So did computers and so did laptops and so did iPads get very, very short of supply everywhere because we did support a number of virtual things. We had already been doing virtual visits. We had done 500 a month and we were, okay with that. But we went from 500 a month to 5,000 a week. And so you have to really understand that the power with which we could deliver some of that technology, we were doing things much faster. I think Brenda mentioned that earlier. We were implementing things much faster than we had ever. We implemented a secure chat feature so that the doctor and the nurse could chat each other securely about things that they needed in order to help save PPE and in order to communicate without coming back out of the room and utilizing more PPE. So not only was it the software, but it was the hardware. And one of the biggest roles that I ended up having to play in this was as people started to understand that they could do things at the bedside with that tablet, what I had to do was to protect the nurse. Because it wasn't just the nurse that should be going into that bedside with that tablet. We had a very active practice with our chaplains, but we had to teach our chaplains donning and doffing so that they were the ones going in with that tablet to ask those questions, to partner up their families to that patient. And it wasn't just that responsibility of the nurse. So we had to really be very careful that we put the work in the hands of the people that really needed to be able to do it. So yes, the televisits on the ambulatory side, we were doing televisits on the inpatient side, connecting our hospitalists when the nurse was in the room so that we were making sure that we had all of those visits taken care of as efficiently as possible. So there were just numbers of things that we did with the technology to make those visits easier. Now people are saying to us, so how do we make all the screening at the door easier so that we're not sitting people there to do that screening? So we've been investigating other modes of being able to use technology to screen people at the door. And everyone's mostly aware and afraid of, do we use that technology? And then when this is all over, what are we going to do? And there will be lots of things you can do with those tablets. So.
For sure, we've all upped our game in technology. That's for sure, especially not only practice but on the education side. But yes. You've all kind of alluded to working across states, working with federal government. How important is coordination among local, regional, state, and federal entities? And I don't know, Sarah, if you want to comment.
Sure, I'd be happy to. So I think when we last stepped back and looked, at least in the state of Illinois, we partner with 52 community county health departments. Again, each health department has a different skill set, capabilities. They have their own interpretation of all of the guidance that they're receiving from their community members. So imagining 52 counties on top of 1,200 providers and about 4,000 nurses, medical assistants, and whatnot. We had our hands full. I think what we've done is just created that unique partnership at the local level in that county. So really just partner with them and say, what is it that you need help with? Where is your role start and where's our stop? Contact tracing, I think, is a really great example of how we've had to partner. When this first launched with COVID-19, we started to see positives. It was, even the patient traveling throughout counties, who was responsible to inform the county, who was responsible to do the contact tracing, and what did the healthcare partner need to do. So again, interpreting that guidance, providing that transparency again to our front line. We continue to partner with the governor's office. Actually, they were calling us probably weekly in I would say April, May, to talk to us about how they could support us in getting the appropriate amount of resources to start testing, because that's really what we focused on, was testing capability. They had the goal of, I think, 10,000 tests a day, and they knew, even with the federal government and the National Guard and others, that they weren't going to be able to achieve that. So they partnered with healthcare partners in the communities. But I think it's been important to create those relationships, because now we're going to see the same with COVID-19 vaccinations. We've already seen from the Illinois Department of Public Health how they plan to do that. And I guess this is a great plug again for ambulatory healthcare, because we've been familiar with this, and we've been vaccinating through state assistance with our vaccines for children. So for children who don't have access to vaccinations, I think it's been really important for our hospital colleagues to partner with us, because we are kind of experts in vaccine. But then how do we vaccinate our employees, what that relationship will look like. So we've continued to, again, partner with each of those counties, because that's how the jurisdictions and the allocations are going to go. So we know that the health departments don't have everything they need to really support such a large ask, such as contact tracing and vaccination. So we continue to partner there. I've not personally been involved with a lot of the federal government, but we do have a vice president of governmental relations, and he's been escalating issues such as telehealth reimbursement. That was really what precluded us from offering telehealth more, was just the reimbursement models. But now that we've been able to entice the federal government to continue this, because they'll see that patient outcome will be improved with this access, I think it's been really important for us.
Okay, any final comments regarding that?
So for us, working with our partners for the first time ever when the pandemic came, so we are mission-based. Our mission is to serve veterans, and that's it. But we enacted a VA fourth mission during the pandemic, and we had civilians come into our facility, and it was really just a great showing of letting down all of our walls of rules and regs, and the mission was just pure healthcare. So we had non-veterans in our healthcare system, and that was through working with state agencies to make that happen. So it was really just an unusual time, but it was a great experience for all of us to be able to partner with our partners in the IMD.
Okay, well, I want to definitely thank you all for this very thought-provoking and interesting perspective on the current and past emergency crises. It's been wonderful to hear how each of you have handled it. I've learned a lot because you've each come at it in a different way from your perspective. So I appreciate you sharing that. But so now we're going to go to some of the questions that we have for you. We have some wonderful comments and questions. And Steve, can you share them, please?
Yeah, I encourage people to go ahead and put the questions in the chat. And we have two already, so I will go ahead and read those. So I think this is from Janice Phillips. Given the magnitude of this pandemic, are there any implications for the recruitment and retention of nurses?
Yeah, I'd be happy to start. I can tell you that is that's probably our number one focus right now for us. We've seen a pretty significant migration. I don't know if it's because we're in the state of Illinois, but we've seen a lot of vacancies actually. Some I think just decided to get out of healthcare altogether. So really we have had a significant struggle with open positions. Again, as I alluded, we were on furlough for quite a while, and then we brought everybody back. We have no one left on furlough, and we have, at least within my area, I know of 52 open nursing positions. So continuing to recruit, starting into high school would be where we're getting down to, and talking about some of those maybe as Brenda talked about, wasn't ever a thought to be a nurse, but really providing some of those experiences with our frontline nurses actually working in the high schools to provide some of that perspective, because I am pretty concerned about what the future will look like for us with our nursing shortage, and medical assistants are another significant population that we work on.
So for us in the VA, we realized that we needed to be self-sufficient should this happen again, because we leaned heavily on some of our sister facilities to have nursing support come in. So we are recruiting very heavily for ICU nurses. So far, so good, but it's just about being ready for when it happens again. And then we've actually changed some of our staffing model guidelines to allow the nurses to have more time at the bedside based on what's required now when you go into a COVID positive room or an influenza room. So we have a continuous open announcement for nursing, and we'll keep it as such until we get to a point of stability with staffing.
Yes, and I don't think we're in the very similar situation to Brenda and Sarah, and doing many things to try and relook at what we're doing. One of the things that we are also doing is during those periods of surge, we have also looked at how do we reduce that documentation burden and actually change that documentation model to be able to better support the nurse so that they felt a little bit more supported. But certainly looking forward, and this hasn't been kind to the nursing shortage in any way. And so yeah, it's going to continue to be a difficult spot to be in.
Okay, another question. This is from Alyssa Brown. In California, especially Northern California, we have had to deal with the fires, another disaster on top of COVID-19. Have you experienced additional problems and how to deal with that? So I guess, natural disasters or the layering of emergencies.
I can certainly talk about, we certainly have not had natural disasters here. I will say the one thing that came up, and maybe Brenda, this impacted you as well, some of the safety that we ran into when we were starting to see some of the disruptions due to some of the political climates, that actually came up quite a bit, where we had to hire additional security, especially in our Little Company of Mary Hospital. And we actually had that in Peoria, where we had to quickly escort our mission partners to and from their vehicles to get them home safely. We actually shut some clinics down. We shut some access down and transitioned patient access to virtual because there was some threats to safety of our staff and providers. So we did handle that. Certainly no other hurricanes, tornadoes, fires, other than the building fire that we experienced. But yeah, certainly my heart and prayers go to Northern California battling those wildfires.
Yes, we only had one building fire as well, but the bigger thing is, in the St. Louis area, we've had quite a bit of the racial tension. And so we've as well had to make sure that our staff were safe getting in and out of the building. And actually, we've done a lot in our own ministries related to a lot more sensitivity and a lot more understanding related to the racial situation and just being more aware of what makes a community. And so again, I think Sarah said it well, and just really the heaping of fire and additional disaster on top of this is so disruptive. I have colleagues and really good friends in Louisiana right now that are very worried about the situation that they're facing with the landing of Delta on the land, and the things that they've prepared for. They had to limit a number of surgeries and limit a number of the things in order to take care of who they have. So, really good question.
Very good question. And for us, it's just been very important to have a good public affairs person to keep their finger on the pulse of what's going on so we can ready ourselves. And we have an all-employee communication system, and we will push out to people what bridges may be closed, what's going on, and what we're doing to ensure their safety. So again, it's kind of trying to stay ahead of what's going on, and being as transparent as possible with communication to staff so that they know that we have their best interests always at heart.
Terrific. Okay, we have time for one more question. It is from Erica Harris. As a correctional nurse, already working in a stressful environment, when COVID hit and the constant changing of information, our stress levels as nurses became overwhelming. And I know many of my colleagues were beyond burnout. What processes and/or interventions has your organization put in place to reduce nurse burnout and/or help improve their mental, emotional health? And maybe we'll start again with Brenda.
Okay, super important question, because I think this is the COVID 1.5 or 2.0 that we are going through right now. COVID, we weren't against a history book, we were making history, and now there has been kind of a strong awareness, for me at least, that people need to talk about what just happened. So we have employee help systems in place, but we hired additional nursing, and we really did a full court press to encourage people to take time off. Initially nobody wanted to take time off because everything was closed, but it was about having those conversations, go home, have a staycation, be with your family, be with your friends, and then offer support services, professional support services we had available to our team as well. And just by talking about the elephant in the room, because as nurses, we think, we're the caregivers, we are not allowed to be the ones in need. But having those conversations in open forums that, no, you've gone through something, undescribable. Let's talk about it. So this way they know that they're part of a whole and not, suffering alone.
Well, this has just been a wonderful discussion. I've enjoyed it immensely. I hope you all also have enjoyed it. And I also want to thank my colleague, Steve George, for facilitating our question and answer session. And again, an enormous thank you to our panelists, Brenda Burke, Lynn Lenker, and Sarah Overton. Let's give them a virtual round of applause. Thank you very much for doing that. And of course, again, thanks to all of you for attending and participating in this very enlightening session. It's been very helpful. I hope you all have some takeaways for your own organizations or practice, for those of you who are still in practice, but I have found it just really stimulating. So I'm going to turn it back to Steve.
All right, thank you, Terry. I'll add my thanks and echo Terry. Thank you, Brenda, Lynn, Sarah, all of you. I want to thank Dean Weaver for her skilled moderating. Now our schedule calls for a short break.